Hi, Josh Kelscher here, our practice director over advisory services at Nordic. Wanted to spend a little bit of time this afternoon talking with Sherry Long, one of our advisory services consultants, about her work in clinical readiness with one of our clients. We do a lot of large-scale, big bang enterprise implementations. Sherry's working on an install where they're already live on the clinical side of the house and then are installing the revenue cycle as well. And so I thought it'd be very interesting to hear kind of a bit about what you're doing and how that may look different and unique for a lot of our folks. So
Sure.
I'm wondering if you could share a bit about yourself and the project that you're working on.
Yeah, so I came into this academic medical center as a clinical project manager. And it involved a lot of work with governance and structure and just trying to get groups together on the clinical side to talk with the other aspects of the revenue side. But then it kind of morphed into clinical integration. Mm-hmm. And then it eventually changed into support for the CMO, the CMIO, and the nursing and ancillary service leaders, which is very characteristic of this type of an install. And it's interesting to me because in a big bang, everybody knows to examine everything. When you layer in, such as this, or if we were putting clinical over revenue, people think, okay, it's almost there, we're just going to add this stuff to it. But in reality, you have to go back and look at every single workflow. And everything that you did in the beginning, you have to kind of re-energize structural things like governance and operational readiness and communication plans. But then you have to go to the bedside workflows and figure out all of the ones that you have to re-examine to determine if there's an impact of what you're implementing. Oftentimes what happens is, like with this customer, we're adding revenue, but we're also adding Optime and Beaker, as well as home health. So there's a little bit of a workflow change because the operating room affects all of the nursing units. There's a difference with pathology and there's a difference with other things. So you have to just really go back and make people pretend like it's a big bang and identify all those workflows and then step through them all to determine the impact. And it's been a bit of a challenge. It's harder because the initial thoughts and the approach to it is not always the same. So people think it might be a little bit easier, but I don't think it is.
It's interesting to hear you say that. I wonder from your experience, Sherry, if you notice that organizations tend to be resistant to seeing it as kind of a whole-scale project where they have to review existing workflows, or if they may just be kind of requiring additional advice and oversight and direction to be able to understand that.
I think a little bit of both, but what I have found to be the biggest challenge is when a site goes up the very first time with the first, phase one, it's the first time that they've had to support through the help desk with all the end users, all of the workflows that are now on Epic. And so they're very busy doing that. And what they don't do is maintain those base things like documenting current state workflows. The workflows change from when they went live and they are modified as they optimize and they add practices and they do a lot of that. And they really kind of leave those things behind. So when they come in with phase two, what happens is you go to pull up a workflow and you realize we haven't been doing that in a while. Well, now we have no documentation. So there's little pieces like that you have to go back and reinstitute. Sometimes the communication or the operational readiness plan resources have left the system.
Yeah.
And so it's kind of like re-examining everything and figuring out how it fits into this new approach. But they do tend to think it's going to be a lot easier, to your point, and they find out very quickly that they have to kind of run and just punt and go with it. It's tough for them sometimes.
And in your experience, Sherry, is that the type of thing where you have to kind of serve in that role where you are re-engaging with the clinicians or with the operations staff that are not involved in the project, or more that you have to kind of work through the existing project team to kind of reach out to those different individuals to start to get them engaged?
A little bit of both. I call myself like the role that I try to play is like a safety net. As they're doing the things that make sense and immediately are intuitive to do, I'm looking in the periphery and all the integration points to think what are we not thinking of? What department, what workflow, what end user, what security has to change, what particular department needs has been having difficulty. We want to come up with a solution for it. Can we do it with the tools that we're adding? So there's a lot of the stuff on the periphery that that my role would try to pay attention to, while the project is paying attention to the things that they know to do, and we're just kind of supporting them in that and prompting for other items as they go along, and kind of making them feel comfortable that nothing will be forgotten. So I kind of see myself in that role. It feels comfortable that way.
And in your experience in the type of work that you do you often have folks on the project team who report to you, or do you often operate independently and kind of work across a number of teams?
Since I've been consulting, I don't have anybody that reports to me. I have had, eventually I've had people ask me if I could just kind of help lead. A lot of it is cross-training. A lot of it is just giving them information about clinical aspects if they're not clinical, or if they're new to Epic, explaining how Epic works so that when they're trying to make a decision about communications or readiness, and they're trying to fill a role or think about a workflow, I just kind of do a little bit of knowledge transfer that just helps make that much more accurate. It's almost like just supporting what they tend to know to do. So a little bit of both. And oftentimes they'll say, would you just help this particular group of people? In this particular case, I'm doing a lot of work with the CMIO and the physician leadership group and their integration with nursing and ancillary services, which is a very key aspect to any type of additional go-lives for systems. Yeah.
Can you dive into that a little bit more? I'd love to hear more about kind of specifically the work you're doing with that group, and certainly maybe some examples you could share of kind of how you've helped them, or provided some additional perspective or direction.
Sure. Well, one of the things when I first came, immediately I was asked, could I help them figure out what's changing? You have these clinical applications and you're adding a couple more plus all of revenue. Which includes patient movement. So it's definitely a revenue functionality within a clinical workflow. So there's a lot of integration that has to happen. But people don't really know, well, we're adding that, but what does it mean? What does it mean to me every day? So I help them come up with a methodology on here's what's new, here's what's impacted, which means here's what's changing. It's a way to approach a lot of different types of projects that are going up in phases. And after we finished that document, it was pretty much the basis for a lot of the communication plan. It was the basis for some of the operational readiness. And they were able to use that information and put it into messaging for targeted audiences to kind of help them get going on their deliverables that are needed in order to move forward in the phases of the project. And
in your role, help me to understand how you interact with the Epic team as well. Are you mainly interacting with ACs, AMs? Are you focusing more on the leadership space? Kind of what does that relationship look like for you?
It seems to focus more on the leadership space, but specifically I have a clinical lead on the project that I work directly with. We meet every week. We keep each other informed. We identify areas in which we need to help. And oftentimes it's where I need to reach out to the Epic partner and say, this is what I've seen, it gives them information to say, here's where we need to support in these particular applications with the different ACs. Or it may be, Epic might need to solution this because I don't think that operations, has the knowledge or the skill set yet to do that. So it kind of just gives them a little bit more insight. Also, on the other side of that is Epic often comes to me to see if I can help support something that they need to get done that maybe needs a little bit more cross-training from the analysts. Or operations, or just that whole, and we really work together to kind of drive some of the outputs that we need to go on to the next stage of the project, and to make sure that it's accurate. So there's a lot of reviewing things, double checking for people, kind of reporting out, and letting each other know the process that we see it on our side, in order to make sure that we're kind of working synergistically. So it's very beneficial.
It would be great to hear, in regards to your specific project right now, if you have an example or two of where the work that you've done has kind of helped to avoid any kind of a negative outcome or situation where you may have had the foresight or the expertise to be able to help kind of steer the ship in a different direction to ensure that project is taking into account the appropriate things from your perspective.
For me, it's lessons learned. I mean, when you are involved in so many different projects, you accumulate a lot of lessons learned. And so when you see something fail again and again, you know where to look. I like to say it's just magic and I know everything about it, but it's just because I've already got the scars from it. And so I'm able to really look at that and say, let's go check this particular workflow, or these end users are often forgotten, or there's lots of different examples of things, but for me, it's about knowing where fails can occur, really understanding the dynamics of a particular institution and their demographics, the way that they practice, and you can, as a nurse, I can kind of tell where they're going to have difficulty, and then I kind of just hone in on it and just dig for stuff. And if nothing's there, then I move on. If there is, we've uncovered it and we can solution it. So it's a little bit of just kind of looking across the whole project and trying to apply everything that I've learned from all of the different implementations and see if there's anything I can use that would benefit that particular customer.
I wonder if you have any advice that you could give to an organization or a consultant who's working on a similar project where either revenue cycle is being implemented after clinicals or clinicals are being implemented after revenue cycle, of like, from your experience, a thing that, hey, if you haven't checked this or you haven't done this or you're not thinking about this, you should do that now.
Yeah. I say it again and again. What I see happen a lot is people want to say, there's revenue and there's clinical. There's ambulatory and there's inpatient. There's phase 1 of the project and now we're into phase 2. There's a point where you can't really distinguish things like that. You have to talk about workflow. You have to talk about integrated workflow and patient throughput through a department, through an office, through the hospital itself, from the doctor's office to the hospital and back and into home health. And so you need to look at it from a holistic perspective and take yourself, I recommend that they always, at some point, take themselves away from those individual silos of thought and look at a patient experience as they move across the care continuum for that particular hospital and ambulatory offices. And it kind of, every once in a while, they'll catch something and they'll say, oh, I didn't even think about that part of it. Just physically moving or how do I make contact with to ensure that I can go on to the next step. And we've caught some really good stuff that way. I think that it's always, for me as a nurse, that's always the best perspective.
I appreciate that perspective a lot. One thing that I've never personally experienced but have heard from some organizations is as they get further along in the EPIC project, they will have some of their senior leadership team walk through workflows as if they were a patient. So I've even heard of organizations that have gone so far as to get in the patient garb and be sitting in the beds and moving from unit to unit, and that can be one of the most kind of profound experiences of understanding.
It is.
Here's the system and the patient that I've been pulling apart this whole time, and now here's how that comes together and where it really matters.
It is. It's really effective, and sometimes it's good to have people that have kind of been there, done that at their side when they have that experience. Because you're able to point out things or have them pay attention to very odd stuff that with a small tweak can make the patient's experience even that much greater. And so if they have a little bit of guidance and support as they go through that, I find that it makes for a much better outcome in the long run. So.
Great. Well, this has been fantastic chatting with you a little bit, Sherry.
Thanks for having me.
Appreciate your time and certainly hope that you've been able to share some tidbits of information that are helpful to some other organizations or some of our other consultants out there. So
I hope so.